The broadcast is now starting. All attendees are in listen-only mode.
Hello, my name is Claire Sinclair and I'm head of the professional development team here at Cardiff University. I'm delighted to welcome you to Cardiff University's free webinar, which we're running as part of our ongoing medical underwriting CPD offering to the insurance sector. The webinar will last for approximately 45 minutes and aims to provide you with a useful learning experience which will give maximum impact while causing minimal disturbance to your working day. This is the second webinar we've run. You may have attended our first one in May. Once again, we're thrilled by the response. As you know, there were only 100 places available, and I'm delighted that all places have been taken. And in addition, we know that a few companies have registered and are showing the webinar on one computer that is visible to a few staff so they can all watch together. During the webinar, we will be tweeting key points, and also a recording of the webinar will be made available online later today. So a few domestics for the session. We'd love it to be really interactive, so you'll see on your screen at the top there's a box which asks you to type in any questions or comments. We have a team on hand to respond to these, be they technical or related to the presentation. So please don't hesitate to drop us a line. You'll be emailed a brief survey once the webinar closes to gather thoughts and feedback for future events, so we'd very much appreciate you taking the time to complete this. So I'd now like to introduce the webinar and Dr. Nick Niven-Jenkins, who will be delivering the session. I'm sure some of you will have been lucky enough to have attended the presentation by Nick before, and therefore will know that he definitely encourages participation and questions. As mentioned already, there is the option to pose questions or just comments to us via the question function. We shall try to answer as many as possible during the webinar. Any questions that aren't answered during the webinar will be answered once it's finished via email. In addition, Nick will use a few interactive polls, and these are multiple choice questions for you to respond to. So let me hand over to Nick.
Hi, today, although it's called arrhythmias, and we are certainly going to look at arrhythmias, what we're mostly going to look at is atrial fibrillation, mainly because it's one of the most complicated things that you and I have to deal with. But before we start all of this, what we need to do really is a quick recap of anatomy and physiology. So if you see the next slide, which shows you the interior of the heart and the four main chambers. Now I'm sure almost all of you know this, that you've got two atria right and left and two ventricles right and left. And the atrium meet at the top, and we call that the apex of the heart, and the ventricles at the bottom, and we call that the base. And the base of your heart points towards your left hand, which is where you feel your heart beating. The left ventricle is by far the largest chamber in the heart, and that's because it has to push blood around what's called your systemic circulation. The following slide shows you what I call a figure of 8. This really just splits up your circulation into two pathways. One venous pathway where venous blood comes from most of your body into the right side of your heart and then into the lungs, and then the oxygenated blood from your lungs goes into the left side of your heart and down through the main arteries of your body, things like the aorta, into the parts of your body of the systemic circulation. So it's a fairly straightforward anatomical structure. So we'll look at one of the questions now, one of the poll questions, just to make sure that you've all got that. So this is about the chambers of your heart. Click on it and answer it if you can.
Okay, Nick, so the results are just coming in. Excellent. This is just a little taster to see if the polls are all working. Yeah, results are pretty strong. We've got 83% there for, going down to 77, somebody's obviously changed their mind, 75% for B. How's that looking, Nick?
That looks good, and in fact that's the correct answer, of course. It's your left ventricle. As I said, it pumps oxygenated blood through most of your body. So now we need to think about the conducting system, because this is where, in most cases, arrhythmias arise, either within this system or outside it. The rhythmic sort of contraction of your heart, we call the heartbeat, and it's generated by specialized cells within your right atrium called the SA node. They're influenced by nerves and by hormones circulating in your body, and in fact if we took most mammalian hearts out of the body, where there was no nervous or hormonal influence, they beat anywhere between about 250 and 500 times a minute. So most of the hormones and most of the nervous activity actually dampens down your heartbeat, so that it, on average in an adult, beats somewhere between about 60 and 85 beats a minute. So we're going to look at this in more detail now. And you can see that the electrical impulses come from the sinoatrial node, the SA node, right up in the right ventricle, pass through the atria, and then meet this other node called the atrioventricular node, which is just within the ventricles. And this checks the signals as it passes through the muscle. Now that's quite important, because people with some atrial arrhythmias or supraventricular arrhythmias, like AF, their atria are going at perhaps 200 a minute, but their ventricles are only beating at perhaps 100, 120. And that's because the AV node suppresses some of these signals coming from the atria. So,
yeah, actually, Nick, I think we had a question sent in before the webinar about that, about LBBB.
Oh, left bundle branch block. Yeah, it says, what are the long-term risks for people who have a left bundle branch block but have been extensively investigated and found to have a structurally normal heart? Left bundle branch block is a fairly straightforward thing to understand, really. If you look at this diagram on the screen now, the red nerve fibre going to the left side, the left ventricle, doesn't work properly in left bundle branch block. What happens is the impulse comes from the atria to the AV node, then passes through to the right ventricle, and then as the right ventricle contracts, the impulse spreads laterally across the left ventricle. So you have a widened QRS complex. The answer is that if in fact everything else is normal and there's no real problem, most people don't have any significant consequence, particularly young people, from left bundle branch block. And the issue around its seriousness is generally regarded as fairly minimal. However, if you've got other pathology, like cardiomyopathy or coronary artery disease, then the outcome can be completely different, and it could be quite a significant problem for you. So that's left bundle branch block. Now, if we go on to the arrhythmias, which is on this slide, basically what is an arrhythmia? Well, it's been defined as a heart beating outside the normal range. Yours and my heart hopefully beats at around 60 to 100 a minute. The healthier you are, the slower it tends to be. In the US, they regard it as 120. So that's thought to be and said to be normal sinus rhythm. Any variation from this, therefore, by definition, is an arrhythmia. And you can see a normal ECG on the screen now. One of the first things we do is to look at ECGs to determine whether you've got a normal heartbeat or not, and a normal tracing. And so almost anybody with any sort of coronary problem will have an ECG done in the first instance. On the next slide, you can see what I've said is that the most common arrhythmia is an extrasystole, and this is true. Both in atrial and ventricular extrasystoles are very common. They're especially common in people who exercise, in young people, and in people who drink and smoke alcohol. And as we get into other arrhythmias like AF, you'll find out that this is true for them as well. Some people suffer from recurrent arrhythmias, particularly extrasystoles, and the sort of variation in them is absolutely enormous, and you can get combinations of more than one arrhythmia. And there are cardiophysiologists spend their life looking at these and thinking how to deal with them. So it's not surprising that it's quite a difficult problem. And when we go into AF in more detail, you'll see that it's not quite as simple as we used to think. Give them some digoxin and it only occurs in people over 65, stuff like that. Transient arrhythmias, particularly extrasystoles and things, don't usually indicate any significant heart disease. So we need to think about the heartbeat and what happens when your heart beats. It's a two-part sort of pumping chamber, really. The upper chamber is the atria and the lower chamber is the ventricle. And in the phase called diastole, where the heart is relaxed, the upper chambers fill and then pass blood into the ventricles. The second part is where the electrical activity spreads down into the ventricles. The ventricles contract and squeeze the blood up through the aortic valve into the aorta and the rest of the body, and through the pulmonary valve into the lungs. Now what we need to do now is look at this next simplified diagram, and I'll explain it to you. It's a way of expressing how electrical activity passes through the heart. You'll see on the left diagram the SA and the AV node and how the atrium and ventricles have effectively been combined. The diagram on the right shows you how activity spreads across the atria and through the ventricles. And we're going to use this form of diagram to explain some abnormalities in the conduction system. So the SA node, as we said before, the onset of depolarization or contraction of the atrial muscles in a healthy heart begins in this focus of pacemaker cells. And it's this activity of these cells which are collectively known as either the sinatrial node or the SA node. Healthy rhythms are classified at, I've put them down below. We tend to talk about tachycardias and bradycardias and sinus rhythm. Tachycardias are a heart rate above about 120 a minute, whereas bradycardias are a heart rate below about 50 beats a minute. In the old days when I was a student, anybody with a heartbeat below 50 beats a minute, we'd fit them with a temporary pacemaker because we thought it's really important that your heart rate be above 50. These days, it's usually around 35 or less. So we look at what is sinus rhythm. This occurs when the sinus node depolarizes spontaneously and the electrical impulse is released from the SA node to cause the atria to contract, as you can see in the diagram. And you can see from the ECG where the P wave is by the arrows. Now, P wave is important because that indicates when the atria contract. And in some arrhythmias, it's quite a diagnostic feature, and we'll come to that a bit later on. So that's sinus rhythm. Just a reminder, really, about the nomenclature of ECGs, because we're going to look at them. Basically, a P wave is activation or depolarization, contraction of the atria. The QRS complex is about the ventricles, and the T wave is ventricular repolarization. Now, some conditions of the heart, particularly where you get extra or ectopic pathways, the waveform will change, and you can make a stab at a diagnosis from looking at the change of the waveform on the ECG. So we'll now look at the atrioventricular node. This introduces, as I said before, a delay in the conduction, which allows the atrial contraction to fill the relaxed ventricles before they contract to pass blood into the lungs of the body. Like I said, it also acts as a sort of gateway in a way to stop too many impulses going through the body, into the ventricles, and therefore allows good ventricular contraction and a decent heart rate. Okay, let's just have a look now at another question. See if you can answer this one.
Okay, we're just waiting for that to come up, I think.
Yeah.
Bear with us just a second. Okay, so the results are coming in. We've got 40% saying A and 61% saying C. It's changing a little bit, but C really that's coming out on top.
Okay, they're both right in a way, although the SA node answer is the most correct really, because that's the origin of your heartbeat. But you're quite right, the AV node plays an important part as well. So it's a bit of a trick question really, but you gain credit for either of those. Okay, thanks. Well, let's get on. So we're going to look at abnormal rhythms. As I said before, they fall into two general types: slow rhythms known as bradycardias or bradyarrhythmias, and excessively fast ones known as tachyarrhythmias or tachycardias. On the next slide, it shows you how we classify them. So we not only look at whether they're tachycardias or bradycardias, but we also look at where they begin. And you can see on this slide that a range of them are either supraventricular or ventricular. An example of supraventricular is SVT itself, atrial fibrillation, atrial flutter, something like that. And ventricular is sort of ectopics, tachycardias, and the worst of all, of course, is ventricular fibrillation. Now, a question came in earlier about Wolff-Parkinson-White syndrome, so this might be an appropriate place to answer it because it's to do with abnormal pathways in the ventricles. The question is, how frequently is Epstein's anomaly present in patients with Wolff-Parkinson-White syndrome? Well, Wolff-Parkinson-White is an extra excitatory pathway in the ventricle, and it sometimes fires off before the pathway that would normally come through the AV node. Epstein's anomaly, which is an issue around the sort of valvelets of the tricuspid valve, occurs in about 50% of these people with Wolff-Parkinson-White. Second part of this question talked about risk stratification for Wolff-Parkinson-White to see which patients are at risk of sudden cardiac death. Now, sudden cardiac death in WPW is actually very rare, occurs in less than 0.6% of patients, but of course you do need to have some way of determining which of these people are suddenly going to die. The easiest way to think about it is that these people's QRS complexes are abnormal merely because you're not getting the normal ventricular depolarization. They're often quite wide, and they also have a funny upward slope. One of the ways, the old ways of testing this was to get people to do exercise, and it's thought that if this peculiar wave, called a delta wave, disappears on exercise, then you're less likely to run into more serious problems with WPW like sudden death. These days, there's a move, more of a move, to excite the atria. So instead of doing exercise to increase your heart rate, what they do is they put a cannula in and stimulate the atria so that your atrial pulse goes up, and therefore in turn through the AV node, so does your ventricular pulse. And again, if the delta wave disappears, it means that your normal conduction pathway is taking over rather than this extra pathway. And again, it's thought that you have less chance of dying from sudden death with that in place. Okay, we'll move on now. Now, what I just wanted to talk about a bit is heart block. You'll hear a lot about this, and we've done a bit about left and right bundle branch block and stuff like that. But it's worth knowing a bit about the AV node and heart block. As I've said before, it's the AV node that controls the number of heartbeats that get through. You'll see on this next slide that what we've done is classified AV block in three ways. In first degree, all of the heartbeats are conducted through the AV node to the ventricles, but the conduction and therefore the action of the ventricles is sometimes delayed. In second degree, some but not all heartbeats get through, and again, some of them are delayed. And in third degree, it's complete heart block, and no beats are conducted from the atria through to the ventricles. So in fact, what happens is you don't get any ventricular activity, and you'll eventually die. So we'll have a look at supraventricular tachycardia to start with, and the one we're going to concentrate on mostly is atrial fibrillation. Now, we call them SVTs because until you're really sure what's causing the tachycardia, you can't define it properly. So you'll often see in reports that this person has an SVT while they're undergoing investigation, and they may not have made yet a significant diagnosis that you can follow, particularly when you're underwriting. And unfortunately, the only thing you can do is wait for the investigations to be finished. But there are some simple ones like atrial fibrillation, and as you see on this slide, it's the most common arrhythmia that we see. It's the most common arrhythmia we see. And one of the reasons to sort of look at it is it's a really significant public health problem. It is associated with people as they grow older, and it certainly does increase with increasing age. And so, as it says here, 50% of the population at age 70 or over have AF. One of the problems with AF from a range of studies, but the Framingham Heart study in 1990 showed it quite clearly, is that it's associated with up to a twofold risk of death because of the fivefold increase in thromboembolic stroke. So there's quite a large number of people who have AF who will end up having some sort of cerebral or cardiac event because of an embolus that's been created in their atria, which are fibrillating. And about a third of people have AF and they don't have any symptoms at all. But a smaller proportion of people do have symptoms, and they vary very widely, from palpitations to shortness of breath, fatigue, dizziness, and sometimes angina. Now you can appreciate that if you present to your doctor with vague symptoms of dyspnea and fatigue and dizziness, it might be difficult to decide what's wrong with you. Do you have a neurological problem or a cardiac problem? And one of the easy ways to tell is just listen to your heart, and you can hear atrial fibrillation just by listening to a person's heart. Some people are symptomatic, and that's important in terms of the way they're treated and their prognosis, because people that are asymptomatic with slow AF, where the rate's been controlled, often don't require any other treatment, but of course if they're symptomatic they do. Now we'll just quickly have a look at the types of atrial fibrillation, because there are three main types, and then NICE in 2006 introduced the fourth type in a way. There's a thing called paroxysmal AF, which, as the term says, is recurrent, and it terminates spontaneously without any treatment, usually within 7 days. In this day and age, if you're subject to fairly frequent paroxysmal AF, what will happen is you'll either be on some drugs long term, or you'll be given what we call the pill in the pocket treatment, which is that you have something like flecainide, you keep it in your pocket, and the first time you start getting paroxysms of AF, you take it, and hopefully that stops it. Then you've got what we call persistent AF. This is just AF that lasts longer than 7 days and doesn't stop without some form of treatment. And then permanent or long-standing AF, which persists for more than a year. And then there's this acute onset AF. Acute onset AF is often associated with younger people. If you smoke heavily and then you go out on the binge at a weekend, you might well wake up on a Sunday morning in atrial fibrillation. Usually, not always, but usually it converts spontaneously as the level of alcohol and nicotine in your blood reduces. But alcohol, nicotine, caffeine, these are all known to be precipitators of atrial fibrillation. Now we'll see that the etiology on the next slide is also quite complicated, and it's usually multifactorial. You can see the risk factors there, being a man, having valvular heart disease. It used to be rheumatic valvular disease, but since the introduction of penicillin, that's much less common. If you've got heart failure, high blood pressure, diabetes, or hypothyroidism, you're much more likely to develop atrial fibrillation. One of the things I haven't put on there is post-operatively. It's not unusual for people to develop AF post-operatively, particularly if they've had some form of cardiothoracic surgery. Then there are some additional risk factors. Age as we get older, a previous history of stroke and diabetes, and all of these place pre-existing AF at even higher risk of some sort of comorbidity such as stroke. Perhaps we'll have a look now, having gone through that, at another poll question and see what you think of this. See if you can answer this. Which of the following is not a known factor in the etiology of atrial fibrillation?
Okay, so just as we're waiting for those results to come in, now don't forget you can send your questions and comments through. Also, I'd be interested to know if you're watching it on a mobile, if it's all working okay, because I think we may have a few issues with the polls, but so just drop us a comment. But I think everything else looks to be working fine. So the results are coming in. A has got 4%. Well, it's kind of spread. B's got 5%, but the top one is C with 78%, with a few going for D. But C, it looks like, is a popular one there, Nick.
Yep, and C is the correct answer. It would be if I could see it. I've lost it now. Anyway, yeah, it is. C's the right answer, because the question is, or was, what is not a known factor in the etiology of atrial fibrillation? Advancing age, high blood pressure, hypertension, and a previous stroke can all be part of the etiology of AF, but treatment with a pacemaker isn't. And in fact, you'll see later on when we talk about it, you can be treated with a pacemaker to actually remove AF.
That's another question just come in, Nick. I don't know if you can read it.
We haven't got to that yet, but does pulmonary vein ablation for AF carry any significant short or long-term risks compared to a treatment procedure?
Do you want to come back to that then?
No, well, we'll do it now if you like. You'll see from the next few slides that ablation around the pulmonary artery is a common-ish procedure these days for treating AF. One of the problems with it is deciding who to treat, and it's thought that the longer you've had your AF, the more difficult it is to treat. Each treatment carries roughly a 3% risk of stroke or heart attack, because when you're converted and your AF goes, and it's similar in to the way we treat them with drugs and electrical stimulation, you've got a significant risk of stroke. And one of the problems with ablation is the longer that you have it for, the more difficult it is to treat. And you might need more than one treatment. You might need up to 3. So you can see that your risk of stroke and heart attack and other complications increases. The long-term effects, well, it's been reported that after a period of time, and I haven't seen any papers with it, the time scale directly quoted, but after a period of time it's thought that people can develop pulmonary hypertension. So it's not something to be undertaken lightly. So what if we move on now to what atrial fibrillation is, and we'll just quickly go over this and then we'll go over the treatment for it. You can see from this diagram, what I've tried to say is that although you've got an SA and an AV node, you've also got other areas in your atria which produce depolarization waves. And so you get this sort of peculiar, unsynchronized contraction of the atria. And some of these are passed through to your ventricles through the AV node. One of the things to note is that on an ECG, in people with atrial fibrillation, there is no P wave. I think it's probably because the strength of the atrial contraction is so small that it doesn't register as a P wave. Now, in the next slide, you can see an ECG which shows you the QRS complexes associated with AF. This is somebody who's rate controlled with a rate of about 7 to 8 beats a minute. And you can see that the waveforms are irregular. What we used to say about atrial fibrillation is that the heartbeat, is irregularly irregular. Everything about it is irregular. And below I've repeated the categorization of AF as we went through in a bit more detail before. So what sort of investigations would you have if you had supraventricular tachycardia, but particularly atrial fibrillation? Well, you need to take a history and a decent physical examination to make sure that you can and decide what sort of arrhythmia they've got, and then an ECG. And these are key to making a good diagnosis, an accurate diagnosis. Almost always, people will have their thyroid function done to exclude hypothyroidism because it is so easy to treat. And if this is the underlying cause of it, then there's no need often to give them any other drugs at all. We look for anemia, so we double blood count, and then we look at kidney and liver function. Now that's mainly to ensure that if they're going to be treated with medication, particularly some modern forms of medication, that their kidneys and liver can cope with it, and it gives us a baseline, because people on these drugs often have to have these repeated in a year. We also do digoxin levels if the person is taking digoxin to make sure that they're not having too high or too low a dose. Now there are loads of other tests that you can do, especially in younger people. You'd normally do a routine chest x-ray, often an echocardiogram, and in some cases where things aren't that clear, we'll do a 24-hour rhythm tape. If somebody's got chest pain and it seems as though it's angina, we'll probably do a coronary angiogram as well, just to make sure that their coronary arteries are not the cause of the underlying AF. What I was going to do was then talk to you about the ways in which atrial fibrillation can be treated, and we'll do that in just a minute. So if we go on to the next slide. We've looked at investigations, now we'll look at treatment. The initial aim is, sorry, I've lost my place on the slides now. The main aim of treatment is to control rhythm, but in some patients, especially those with really long-standing disease, this isn't always possible, and so what we tend to do is focus on the rate. There's a good article in last month's BMJ about this. And one of the reasons we're not too bothered about it is that 2 large trials demonstrated that really the prognosis for people wasn't any different whether you controlled their rate or whether you controlled their rhythm. So what do we use? Well, for rhythm control in the UK, we'll use things like flecainide or amiodarone. One of the problems, though, is that about 40 to 70% of these people, these drugs aren't effective and or they have significant side effects. I think we could move on to the next slide. Okay, so that's rhythm control. Rate control usually uses beta blockers and some form of calcium channel blocker. They're effective at rest and sometimes on exertion as well, so they're quite good. And almost everybody with AF is treated with some form of anticoagulation. The commonest thing in this country is either aspirin, if they're at low risk, or warfarin, if they're at high risk. Anticoagulation, particularly with warfarin, reduces things like stroke risk by 3-fold. So it's a really important issue when we're thinking about it. Other treatments for AF, next slide, are either pharmacological or electrical cardioversion. In pharmacological cardioversion, we tend to give people drugs intravenously, although there's a move afoot now to give them high doses orally, but usually intravenously while they're sitting in a hospital bed and we're monitoring them and we wait to look to see if they've gone back to normal sinus rhythm. You can do external or internal electrical cardioversion. The external one is the CLC in television and casualty, where they put paddles on your chest and zap you. I have to say it's not quite as simple as that. It's controlled by a computer that's looking at your ECG and chooses the appropriate moment to give you the shock. And similarly, you can use internal cardioversion by using wires put up through the groin into the heart, just like you do when you're doing a coronary angiogram. There's really no difference between the sort of pharmaceutical and electrical form if they're used as initial treatment. But if people have got permanent atrial fibrillation, what we often do is start off with a chemical and then follow it by electrical cardioversion if the chemical doesn't work. And that seems to be more successful in these people at maintaining them in sinus rhythm at about 1 year. Short duration AF of less than 48 hours, we would normally use some sort of pharmacological intervention, and often these people don't need anticoagulation either, particularly if they go straight back into sinus rhythm. And in some cases, it's necessary to use both, one after the other. The next thing you'll see up there is what we were talking about before, catheter ablation. And now it's suitable for patients with no underlying structural or valvular disease, so they can't have any underlying sort of heart problems, including coronary artery disease, which would create problems during the procedure. And actually, in patients under about 60, there aren't many who fall into this category, only about 2% of patients. And this recent article in the BMJ showed that actually the best effect was with people who had paroxysmal disease. So it is still used in persistent AF, but it doesn't seem to have as good an outcome as it does with paroxysmal disease. Now, I'll just mention about pharmacological treatment, because you'll see a whole range of drugs used, either singly or in combination. Now, there's an old classification system of what we call these anti-arrhythmic drugs, and it's called the Vaughan-Williams classification system. It's not totally good, but it works quite well. And class 1 of these are sodium channel blockers, class 2 are beta blockers, class 3 are potassium channel blockers, and class 4 are calcium channel blockers. And for something like atrial fibrillation, you'll see that all of these classes will be used depending on the person's age, any underlying pathology and stuff like that. I was going to go on to another question now about treatment. So we'll look at this other poll about which of the following statements is untrue about atrial fibrillation. So it can be treated pharmacologically, treated with internal cardioversion, rate control is better than rhythm control, has a poor prognosis in people with mitral valve disease. Which is the untrue answer amongst these?
Oh, the results are coming in, and it looks like that's very clear, 100%. Oh, now it's changing. It was very clear. And the majority are saying C, Nick.
Yeah, that's true. Rate control and rhythm control, as I said before, the outcome is basically similar. So rate control isn't better than rhythm control in most people. You're thinking about which is the most true statement, which is the one on it has a poor prognosis in people with mitral valve disease. That's true if you're looking for the true answer. You're right. So the answer really was that rate control is no better than rhythm control overall. Okay, so we're finished with that bit. There's quite a lot of detail on how you deal with people with persistent, permanent and paroxysmal AF, and I won't go into it in detail now because it would take far too long. But there are procedures for selecting people and the sort of treatment they have. And so, for instance, in persistent AF, we treat people who are over 65 and those with coronary artery disease and those with some form of congestive heart disease differently to those who are asymptomatic and are younger. So you'll find there's a whole myriad of different types of treatment used. And if you like, at the end of this, what I'll do is put up for you the sort of overview, if you like, of how you treat persistent and permanent AF. These are sort of, if you like, nice guidelines, really. Paroxysmal AF is not quite so easy, as it's treated in different ways according to which centre you go to. So, if we go on to the next slide, this looks at atrial fibrillation overall, okay? And if we're trying to convert them to sinus rhythm, the longer they're in AF, the more likely they are to develop some sort of thrombotic problem. So we need to warfarinize them. If it's been present for less than 48 hours, we can convert them without warfarinization. The embolic events occur following cardioversion because the atrial function returns to normal and the blood stagnates a little and therefore begins to clot. In susceptible individuals, we can pace them, and so we can give them pacing devices. And in fact, at the moment in some hospitals, particularly in the south, where I come from, for instance, if you've got paroxysmal AF that's converted to permanent AF and you've had it and you're symptomatic, what they'll do is they will ablate your SA node and fit you with a pacemaker, which prevents you from ever returning to AF. So your symptoms disappear. So if you get angina because of it, and you're free from coronary artery disease and things, then that disappears. And there's some very fancy pacemakers these days whereby it detects that you're doing exercise, so it increases your heart rate. So overall, every atrial fibrillation carries particularly poor prognosis when it's associated with mitral valve disease, an enlarged atrium, high blood pressure, the older you are, and whether you've got diabetes, and whether you have any previous history of embolism at all. This is because the hemodynamic changes that take place are related to the rapid and irregular heart rhythm, and that's when the thromboembolic complications arise. So let's have a quick look at ventricular arrhythmias before we finish. This refers to any cardiac arrhythmia arising in the ventricles or in the AV node. One of the problems, as we saw in Wolf, Parkinson, White, is that if you get conduction irregularities because the impulse bypasses the AV node, you can run into some trouble. Things like recurrent or reentrant arrhythmias are often referred to as ventricular pre-excitation arrhythmias. So let's have a quick look at ventricular ectopic bleeds. This is the most common ventricular arrhythmia, just as it is the atrium, and causes ventricular contraction before the underlying rhythm would normally depolarize the ventricles. Now, one of the problems with electrical systems, particularly muscles, is that once a muscle has contracted and depolarized, there has to be a latent period to wait for the muscle fibers and the ions around them to get back to the resting state. And what most people notice with ventricular ectopic beats is they feel as though they've missed a beat. And this is the period of rest that the ventricles need to go through before they can contract again. And that's the thing that most people notice, and that's often the thing they first go to the doctor about. They can, of course, like all these things, indicate some underlying heart disease, and so if you have them persistently and frequently, that needs to be taken into account. But some of the commonest causes of these things are things like alcohol and caffeine and medications, including cocaine. But they can occur naturally, in which case almost all of them are fairly innocent. So these ventricular ectopic beats are quite interesting because they can occur in different ways. They can either be collected together and occur every other beat, every third beat, or every fourth beat, which is you can see on the next slide. But they also occur in sequences, so they occur as sort of couplets and triplets, and what's called salvos. And anything more than 7 is not a salvo anymore, it's an episode. And you can see in the tracing below this thing called bigeminy, which is where it occurs every other beat is an ectopic beat. And this can be quite disturbing to people and feel quite strange. We'll go on to look at ventricular tachycardias because this is getting near the end of the presentation. We had one other question come in which I'll talk about after we've done this, which talks about ventricular ectopic beats and post-exercise syncope. This sounds as though it's probably a case, and it's one of these really complicated things where you've got more than one abnormality going on at a time. Anyway, we'll look at ventricular tachycardias to start with. And what you can see is that the tachycardia is caused by what's called a reentrant abnormality. And this is where the beat goes through to the ventricle, and then the ventricle all on its own starts producing more and more contractions. Now, this is important because although the majority of them often stabilize and revert to sinus rhythm, some can degenerate, and they degenerate into ventricular fibrillation. And as you see on the next slide, VF is a completely uncoordinated contraction of the ventricular muscle. Your heart fails to fill up, so you eventually suffer from oxygen lack called hypoxia. And we regard it as a medical emergency because often if it goes on for more than about 3 minutes, you can start getting permanent brain damage. So it's a big issue, and it's particularly a big issue if you don't live very near a hospital. If you live in a hospital, well, not live, but if you're staying in a hospital for some other reason and it happens, the chances are you'll survive it because they'll have defibrillators around. If you are in Cardiff station, however, you won't, because there is no defibrillator on the station complex. So this is the importance of teaching people how to use defibrillators, because as you can see on this slide, this is completely incoordinated, small contractions which don't do anything for you at all. They're twitches really, and you can end up dead from it. So arrhythmias in general, I'll come to that in a minute. Arrhythmias in general, on the next slide, you can see that prognosis depends on the type. There may be no excess mortality, for instance, with extrasystoles, or very high mortality like ventricular fibrillation. One of the problems is, in almost all cases, there's a worse prognosis if it occurs with any other aggravating factors such as cardiac ischemia or coronary artery disease. Questions come in about R on T, which I'll answer by email afterwards, but what I think we'll try and do is very quickly run over this. What are the risk factors for people who have ventricular ectopic beats with post-exercise syncope when the cause is indicated to be neurogenic rather than cardiac? Now, this is quite a complicated question, and in fact the person who has this sort of condition would almost certainly be referred to a cardiophysiologist to try and sort it out. We've talked about ventricular ectopic beats, and as I've said, in young and healthy people, they're generally innocent, but they don't have to be. And the same with what's called neurogenic syncope. This is a term used to show that there's nothing wrong with the heart, as is said here, because they've been investigated by 24-hour tapes and echoes and things, and they've all been normal. It's very common in young adults, And what happens is that you take some exercise, your heart rate goes up, and either during the exercise or after the exercise you faint. Now, the reason for this is thought to be that muscle activity during exercise pumps more blood, a bigger venous return into the right atrium and right ventricle, and keeps your blood pressure up. When you stop exercising, this muscle pump decreases, your blood pressure drops, and you faint. I'm not aware of the issues surrounding these two things occurring together. I do know that if you get exercise syncope while you're exercising, it's thought to be more of a problem than afterwards. And of course, if you've got some underlying neurological disorder, particularly that affecting your heart or vagus nerve or something, then the prognosis can't be very good. But again, what I'll do is have a look at this and see if I can find any indication in any recent papers about it. So that completes today's presentation on arrhythmias.
Well, many thanks, Nick, for the presentation, and thank you all for participating with your questions and answers to the polls. There were a few questions that came in that we haven't had time to answer, but as Nick referred to, we'll be sending out an email with those questions and some answers as well. But yeah, thank you very much for participating. Apologies if there was a few technical issues over the polls on mobile devices, but it looks like that was sorted as well during the webinar. Just a reminder, the full webinar will be available online later today. There will be a brief survey once the webinar closes to gather thoughts and feedback for future events. So we very much appreciate you taking the time to complete this. We're planning to run another webinar before the end of the year, so suggestions on topics would be really great. If you have any photos from today, if you're watching the webinar together, a couple of you around a computer, then do take a photo and maybe tweet it to us or email it to Charlotte. You can, of course, use our hashtag, which is being created for these events, MedRiskWebinar, hashtag MedRiskWebinar. So do use that if you want to. But as I said, this is the second webinar that we've run, so thank you very much for participating, and many thanks to the support team here at Cardiff University. Big thanks to Charlotte, to Gail, to Katie, who's been tweeting, and of course Nick for a wonderful presentation. Thank you very much, and we'll speak to you again soon. Thank you. Bye-bye.